And next is the qualitative, is three things. One is the MCV, that is mean corpuscular volume, next followed by mean corpuscular hemoglobin, and then it's the mean corpuscular hemoglobin concentration. So first we'll see what is hematocrit. It is a packed cell. It is the proportion of volume of blood sample that is occupied by RBC. So it is expressed in terms of percentage. For men, it is the range between 42 to 52, and for women it is 36 to 48%. And next is the hemoglobin concentration. It is the amount of hemoglobin per unit volume of blood expressed in grams per deciliter. For women, the normal is 12 to 16 grams per deciliter. For men, it is 14 to 17 grams per deciliter. In simple terms, you can say, suppose the hematocrit is 30%, so 1/3 of the hematocrit will comprise as the hemoglobin. That means the hemoglobin will be 10. For example, 36, the hematocrit means the hemoglobin will be roughly 12. And next is the red blood cell per unit volume. That is the normal value ranges between 4.7 to 6.1 millions per microliter. Next is the qualitative parameters. It is the MCV. It is the average volume of RBCs. It is expressed in femtoliter. The normal range is 82 to 98. And based on this, we will classify the anemia that we will explain in the subsequent slides. And next is the mean corpuscular hemoglobin. It is the average hemoglobin content per RBCs. The normal value is 27 to 31 picograms per liter. And next is the mean corpuscular hemoglobin concentration. It is the average concentration of hemoglobin in a given red cell volume expressed in grams per deciliter. So normal is 32 to 36. So you can easily remember this MCH and MCHC roughly between 25 to 30. And this MCV will roughly between 80 to 100. You can remember, suppose the MCV is less than 80, it is called, the cell is microcytic, and the MCV is more than 100, it is called macrocytic. And if it ranges between 80 to 100, for simple terms, it is called normocytic. So remember this MCV, because based on this only we will classify the various anemias. Yeah, this is the classification of anemia. Anemia may be classified morphologically based on the average size of the cells and the hemoglobin concentration. So based on the previous slides, if the MCV is more than 100, that means the size of RBC is more than 100 femtoliter, it is called macrocytic or megaloblastic anemia. If it is 80 to 100, it is called normocytic and normochromic. If it is less than 80, it is called microcytic or hypochromic. You can able to appreciate the entire cells. You can able to see the platelets, WBCs, and the red blood cells in the first slide. And next you can see the microcytic. The cells, the RBC size is less. That means the MCV is less than 80. And next in macrocytic, the size of the RBC is high. It's large. So the MCV is more than 100. It is called macrocytic or a megaloblastic. And based on the pigmentation, it is if the hemoglobin level is less, it is called hypochromic. And if it is, the cell is having both the size and the chromosity is less, it is called microcytic and hypochromic anemia. So this is the differential diagnosis of anemia based on the MCV. So MCV is less than 80, it is called microcytic. 80 to 100 is called normocytic. More than 100 it is called macrocytic. First we will see the microcytic anemia. The MCV is less than 80. You can remember with the mnemonic called tics. I used to remember in my MBBS days as a tics. That is thalassemia, iron deficiency, anemia of chronic disease, and sideroblastic anemia. So among this, iron deficiency anemia stands first in the list, followed by anemia of chronic disease, thalassemia, sideroblastic anemia. So you can remember this microcytic anemia as tics: thalassemia, iron deficiency, anemia of chronic disease, and sideroblastic anemia. Next is the normocytic anemia. So the MCV will be somewhere between 80 to 100. It can be further classified into hemolytic and non-hemolytic. Hemolytic can be further classified into intrinsic problem and extrinsic problem. That is, problem within the red blood cell, or it can be a problem outside the RBCs. So I already told the normal RBC is having a biconcave disc shape so that it can squeeze easily into the systemic and pulmonary circulation. Suppose the shape of the RBC has lost, or there is enzyme deficiency. In those conditions, there is a high chance of hemolysis. That means the the red blood cells cannot withstand the wear and tear during the circulation. During the travel inside the blood vessels, there is a lysis of these RBCs. So that is the reasons, mainly the conditions called hereditary sperocytosis and the condition called paroxysmal nocturnal hemoglobinuria and G6PD deficiency, pyruvate kinase deficiency and sickle cell anemia and hemoglobin C disease. There is an intrinsic problem within the RBCs. Either it can be a problem within the cell membrane or there is enzyme defect inside the RBCs will cause us hemolysis. And next is the extrinsic cause, like microangiopathic hemolytic anemia, which we call as MAGA. That is, during the squeezing of this RBCs into the smaller blood vessels or the capillaries, there is a lysis of these RBCs. Or the next is the macroangiopathic hemolytic anemia, and third is the autoimmune hemolytic anemia due to production of autoantibodies against the patient's or the body's own RBCs. And next is the non-hemolytic cause. In the non-hemolytic, iron deficiency anemia is also one of the major cause. And next is the anemia of chronic diseases like rheumatoid arthritis, SLE, or patients with collagen vascular disorders will have non-hemolytic anemia picture. And next is the anemia of chronic diseases and aplastic anemia. Next in the list is the macrocytic anemia. So in the macrocytic anemia, that means MCV is more than 100. It could be either a megaloblastic or a non-megaloblastic. In the megaloblastic, the commonest causes either the folic acid or the B12 deficiency is the major cause. And next is the copper deficiency. And next is the orotic aciduria and drug-induced allopurinol. There is a condition called pernicious anemia, which is an autoimmune condition which usually occurs due to production of antibodies against the intrinsic cells. So there will be a defect in the B12 deficiency and folic acid metabolism. And next is the non-megaloblastic cause. In the non-megaloblastic, it could be due to an alcohol excess usage or liver disease. So the classification of anemia, microcytic means, remember, ticks, thalassemia, iron deficiency, anemia of chronic disease, and sideroblastic anemia. So ticks is the mnemonic. The size of RBC is less than 80. If the MCV is more than 100, it could be either a megaloblastic or a non-megaloblastic. The size of the RBC is more than 100. It is called macrocytic. It could be either a megaloblastic or non-megaloblastic. Among megaloblastic, it is a B12 deficiency or a folic acid deficiency. If the RBC is normal in size, that is, it's called normocytic, it could be a hemolytic or a non-hemolytic. And the hemolytic can be an intrinsic cause or extrinsic cause. And among the non-hemolytic, anemia of chronic disease like rheumatoid arthritis and CKD. Because chronic kidney disease patients will have a diminished erythropoietin synthesis. So eventually what will happen? The production of RBC also will be decreased. And next is the bone marrow dysfunction. Due to drugs, infection, radiations will cause us aplastic anemia. We'll have a brief discussion about reticulocytes. I already told reticulocytes, it is a precursor of RBCs during the productions of various cells, right from starting from pluripotent cells to RBCs. The reticulocytes is the precursor to the red blood cells, and like RBC, it also doesn't have nucleus. The reticulocyte count is the most effective measure of erythropoietic activity. Reticulocytes counts are a reflection of bone marrow health or injury. Suppose the bone marrow is not functioning properly, what will happen? The reticulocytes counts is less. The conditions like myelofibrosis or conditions like myelodysplastic syndrome or post-chemotherapy or post-radiations or drugs like chloramphenicol will cause us bone marrow suppression. So what will happen? The synthesis of the red blood cells itself will be decreased. So if the reti count is less, that means the production is less. Suppose if there is a hemolysis, what will happen? The body will try to compensate by producing excess RBCs. So the reticulocytes counts will be high. So if the reticulocytes counts is high, means there is hemolysis or blood loss. If the reticulocyte count is less, that means the production itself is diminished or hampered. So it provides a crucial information on rate of red cell production. So red cell loss or destruction means, that is hemolysis, there will be increased reti count. Example is hemolysis or blood loss. And decreased red cell production is due to aplastic anemia or iron deficiency. That is nutritional or malabsorption syndrome. So in this slide flow chart, we will discuss about macrocytic anemia. If the MCV is more than 100, it's called macrocytic. So based on the reticulocyte count as the baseline parameter, this RP is nothing but the reticulocyte production index. If the reticulocyte production index is more than 2, that is it's high. That means there is some amount of hemolysis is happening. So if the patient is having a fragmented cells like histiocytes or Burr cells in the peripheral smear, that means there is hemolysis. If there is no fragmentation, that means there is only acute blood loss due to hemorrhoids or peptic ulcer disease or patients having excess menstruation. In those conditions, the RPA will be high. That means the body will try to compensate. The erythropoietin synthesis will increase from the bone marrow. The excess RBCs will be produced. So in both hemolysis and hemorrhage, the RP will be more than 2. Remember this flow chart because we are using the subsequent slides also. Suppose if the RPI, that is a reticulocyte production index, is less than 2, it could be due to if the macrocytic is, if the MCV is more than 100 and RP is less than 2, it could be due to either a B12 or a folic acid deficiency. Either way. Or if the B12 and folic acid level is normal or high, it could be due to, next check the WBC and platelet count. If it is decreased, it is due to aplastic anemia or a myelofibrosis or a myeloid dysplastic syndrome. If it is normal, it could be due to drug inhibition or a liver dysfunction. Next slide we see it's a normocytic normochromic. That means MCV is between 80 to 100. So first we see the reticulocyte count as a baseline parameter, and based on the previous flowchart, if the RPA is more than 2, it could be either hemolysis or hemorrhage. And if the RPA is less than 2, next we see about the WBC count and the platelet count. If the WBC and platelet count is decreased, that means there is a pancytopenia. So the entire marrow is not functioning properly. So there is a bone marrow suppression. If the WBC and platelet count is normal, and then only the hemoglobin is less, then you can check it, the serum iron and the TIBC. If the serum iron and TIBC is decreased, it is due to anemia of chronic disease. And then if it is normal, check the renal function studies. If it is abnormal, it could be either a chronic kidney disease. If it is normal, check the bone marrow, it could be due to a pure red cell aplasia. And next is the microcytic or the hypochromic anemia. That means MCV is less than 80. So next is check the serum iron. If the serum iron is decreased, then check the total iron binding capacity. If the iron is less and the binding capacity is more, that means it could be due to iron deficiency anemia. That means either supplemental iron in the diet is less or there is a malabsorption. Both the condition will cause us the availability of iron in the plasma will be decreased. So the body binding capacity, the affinity of the body for the iron will increases. So TABC will be high in iron deficiency, whereas the TABC will be normal or decreased in anemia of chronic disease due to conditions like rheumatoid arthritis, SLE, or any vasculitis. So remember this. So in both anemia of chronic disease and iron deficiency, there will be a decrease in iron, but the TABC will be more in iron deficiency. The TABC will be normal or decreased in chronic diseases, because what will happen in anemia of chronic disease, the storage form of iron will be in adequate amount, the ferritin will be in adequate amount. So only the utilization is decreased. And next is, if the serum iron is normal or increased, look for the percentage of saturation of iron. If the percentage of saturation of iron is markedly increased, it is called sideroblastic anemia. If it is normal, then please check the hemoglobin electrophoresis. If it is electrophoresis is abnormal, it is called thalassemia or hemoglobinopathies. If it is normal, then look for basophilic stipplings. If it is present, it will be due to lead poisoning. If it is absent, it's called a porphyria. Porphyria is nothing but it is a defect in the heme synthesis. We will not cover those topics. We will not go into the detail about the porphyria. So anemia classification, if the MCV is less, it is microcytic. Then check the ferritin level. If the ferritin level is low, it is iron deficiency. Remember, in iron deficiency, everything will be low. The ferritin will be low, and this hemoglobin will be low, and then this MCV will be low. But only thing is this TIBC, the affinity will be more in iron deficiency, except everything will be low. Whereas in microcytic, if the ferritin is level is normal, then look for electrophoresis, and patients might have thalassemia. If the patient is having normocytic, look for reticulocyte count. If it is increased, it is simple, it is hemolysis. If it is decreased, it is marrow is not functioning properly. So which we already discussed about the reticulocyte count. If it is macrocyte, then check the B12 and folic acid level, or it could be due to non-megaloblastic also will be the another reason for megaloblastic anemia. So remember, macrocytic means it is B12 and folic acid is the commonest cause, and microcytic, first thing should come to your mind is iron deficiency and thalassemia minor. In normocytic, the reticulocyte count is high means there is hemolysis or blood loss or hemorrhage. If it is less means the bone marrow is not functioning properly, like conditions like leukemias, lymphomas, myelodysplasia, myelofibrosis, or any drugs or chemotherapy induced bone marrow suppressions, or certain viral infections like parvovirus B19, which also will cause aplastic anemia. So this is the microcytic anemia. Many RBCs are smaller than nucleus of normal lymphocytes. There is an increased central pallor. You can able to appreciate the chromosity has been lost. It includes the mnemonic is tics, thalassemia, iron deficiency, anemia of chronic disease, and sideroblastic anemia. So the next we'll see about the iron deficiency anemia. The common cause is nutritional and malabsorption symptoms like tropical sprue, celiac sprue, or patients might have some worm infestations like ankylostoma duodenale. Hookworm infestations also will cause us iron deficiency anemia. Next is the bleeding conditions like hemorrhoids, gastric ulcers, menstrual blood loss, and worm infestations also attribute to iron deficiency anemia. So remember, absorption primarily absorbed in the duodenum, transport, the iron is transferred as transferrin and stored as ferritin, and hemosiderin is derived from ferritin, which is the long-term storage of iron. So in the lab studies in iron deficiency anemia, it's simple. Everything will be less. The MCV will be less, MCH will be less, MCHC will be less, except the TIBC will be high. That is, the body will have more affinity for iron to compensate as a compensatory mechanism. And the ferritin, the stored form of iron also will be less, and the saturation also will be less. So remember, in iron deficiency, except TIBC, everything will be low. Next is the treatment of iron deficiency anemia. It's simple. First, you have to check for the root cause. What is the cause, whether it's nutritional or malabsorption or there is a blood loss. Address those things, and then you can supplement by either oral or parenteral. Remember, if the patient having oral iron supplements, patients might have constipation, so you can add lactulose or a prokinetics to the patient, or advise the patient to take a more fiber diet. Next, we'll see about thalassemia. It is a genetic disorder. Remember, thalassemia, it is a genetic disorder due to lack or decreased synthesis of globin chain. So the synthesis of it is a decreased synthesis of the globin chain in the hemoglobin molecule. Two types. One is alpha, next is the beta. The alpha chain is encoded by 2 pairs of genes on chromosome 16, and beta chain is encoded by single pair of genes on chromosome 11. Beta thalassemia is more common and present as either a beta thalassemia minor or major. So this is the geographical distribution found frequently in the Mediterranean, African, Western, Southern Asian, India, and Burma. The distribution is almost parallel to that of Plasmodium falciparum. So among the alpha thalassemia, there are, if the 4 genes are intact, it's normal. 3 genes are intact, silent carrier. 2 genes are intact, it is alpha thalassemia trait. 1 gene is intact, it's hemoglobin H disease. If none of the genes are intact, get mutated, it's called hemoglobin Bart or hydrops fetalis. In the beta thalassemia, it is minor, major, and intermediate are the 2 major classifications. And among thalassemia, beta thalassemia is more common than the alpha thalassemia. So what happens is there is a reduced beta globin synthesis. Normally, the adult hemoglobin, in this picture you can able to appreciate, normal adult hemoglobin will have 2 alpha and 2 beta 2 chains. So alpha 2 and beta 2 is the normal adult hemoglobin. What happens here in thalassemia, there is a reduced beta globin synthesis with relative excess of alpha globin chain. So in beta thalassemia, the abnormal erythroblast will have insoluble alpha globin aggregates, and what happens, there will be a increased destructions of the red blood cells. So that is the reasons these patients will present with hepatosplenomegaly. There is extravascular hemolysis happens inside the body in the reticuloendothelial system. And another reason for increased liver hepatomegaly is not only the increased iron deposits in the liver, frequent blood transfusion also will cause us hemochromatosis and hemosiderosis. And because of defective globin synthesis, and when the RBC is less, the body will try to produce excess RBCs from the bone marrow. So that is the reason for this thalassemia patients will have a peculiar thalassemic facies. There will be malar prominence, the skull will have prominent. In the radiologically, we will have a condition called hair on hand appearance. So the bone marrow is hyperplasia happens in the entire body. So these patients will have altered facial, and there will be a difficult airway for these patients. And there is an increase in the iron load. So this will affect the liver, this will affect the spleen. So there will be hepatosplenomegaly, and the excess iron also deposits in the gonads and the pituitary gland. So these patients will have a lot of complications like hypopituitarism or hypothyroidism or hypoparathyroidism, and this excess iron deposits will also occurs in the heart, leads to hemochromatosis of the heart. So the pumping capacity of the heart also decreased. In these slides, you can able to appreciate, since these patients need repeated blood transfusions, these patients are at not only risk of excess iron overload, the chance of infections like hepatitis B, HIV, hepatitis C, syphilis, and malaria is more in this patient. And then there is hypopituitarism, excess melanin skin pigmentation, a condition called bronze diabetes. There is hypothyroidism or hypoparathyroidism, and this cardiomyopathy due to excess iron deposition in the heart. And because of extramedullary hematopoiesis, there is a malar prominence. This patient will have a particular thalamic facies. And because of extravascular hemolysis, there is a splenomegaly, and this excess iron deposition in the joint also causes arthropathy, osteoporosis, and then short stature. And because of iron deposition in the gonads and the pituitary gland, these patients will have testicular or ovarian failure. And coming to treatment for this patient, one is you can transfuse with the normal red blood cell, and then the curative, it is the hematopoietic stem cell transplantation, and experimental therapy is erythropoietin and fetal hemoglobin modifiers and antioxidants. The future therapy is the gene therapy. And next is the anemia of chronic disease. So chronic infections or like tuberculosis or rheumatoid arthritis or SLE, The autoimmune conditions, rheumatoid is not infection, it is like autoimmune conditions and SLE, and collagen vascular disorders, vasculitis, like certain malignancies will causes anemia of chronic diseases. And next is the sideroblastic anemia. In the sideroblastic anemia, the availability of iron will be in abundant amount, normal amount. But only thing is what happens in what is the pathophysiology behind the sideroblastic anemia? The synthesis of hemoglobin is not proper due to the genetic mutation. Otherwise, the hemoglobin, the iron level, the serum iron level, and the ferritin will be in adequate amount. So these patients present with moderate anemia with hematocrit ranges between 20 to 30%. The serum iron and transferrins are elevated. MCV is usually normal or slightly elevated. Diagnosis is usually made with bone marrow biopsy. You can able to appreciate in the slides. There will be ringed sideroblast. So usually made via the screening program. Onset of symptoms, there will be history of pica and family history of lead poisonings might be there. So patients, the physical examination, patients present with pallor, hyperactivity. So you can able to see the blue lines, that is the Bartonian lines in the gums, decreased stature, or patients might present with wrist drop or cognitive dysfunctions. And there will be CNS disturbance as well. So this flow chart you can able to appreciate to how to diagnose from iron deficiency or anemia of chronic disease or sideroblastic or a thalassemia. Suppose the patient is having a microcytic anemia, then check the serum iron, the TIBC, that is a total iron binding capacity, and next is the percentage of saturation and the ferritin. Ferritin is nothing but the stored form of iron. Remember like that. First we see the iron deficiency anemia. I said everything will be less except TIBC. So serum iron will be less, ferritin, the stored form of iron, and the saturation also will be less, whereas the binding capacity as a compensatory mechanism will be more in iron deficiency anemia. Whereas the anemia of chronic disease, you can able to see it how it differs from iron deficiencies. The serum iron will be less, whereas the ferritin will be normal or high. So that is the reason the TIBC will be less in anemia of chronic diseases. Whereas in sideroblastic, everything will be normal. The availability of iron, the ferritin, the saturation will be normal. So it's exactly the converse of iron deficiency anemia. The TIBC will be less, the affinity will be less. So remember iron deficiency anemia and sideroblastic. So in sideroblastic, the serum iron, TIBC, saturation, and ferritin will be exact opposite to the iron deficiency anemia. In thalassemia, everything will be normal. So in a nutshell, iron deficiency, everything will be less except TIBC. And sideroblastic anemia is the exact opposite of iron deficiency. In anemia of chronic disease, iron will be less, and since the ferritin, the stored form of iron, is more inside the liver and the spleen, so the affinity will be less. In thalassemia, everything will be normal. You have to undergo, the patient should undergo electrophoresis study. Next is the macrocytic anemia. The macrocytic anemia is further classified into megaloblastic and non-megaloblastic. Remember two things, B12 and folic acid as the major cause for macrocytic. So the patients present with non-specific signs and symptoms. Relatively, they have low reti count. And another interesting thing is these patients will have hypersegmentations of the neutrophils. And the patients with B12 deficiency will have neurological dysfunctions. Patients might have ataxia or lack of proper gait. Patients will have gait disturbances in B12 deficiency, like ataxic gait or psychomotor retardations and seizures. So you can able to see these neutrophils. There is hypersegmentations, which has a multiple lobes, around 5 to 6 lobes. More than 5 to 6 lobes will be present in the peripheral smear of the megaloblastic anemia patients. In this slide, you can able to see the small black arrows. There is a erythroid hyperplasia, and the yellow arrow detects the megaloblastic changes, and arrowheads shows the dysplastic blood cells. this slides you can able to differentiate the differences between the B12 and folic acid. Both have MCVs more than 100, and both have macrocytosis with hypersegmented neutrophil. And pernicious anemia, it is an autoimmune conditions which is associated with B12 deficiency, and homocysteine level is elevated in both the conditions. Whereas this methylmalonic aciduria will be elevated only in B12 deficiency, and this will be a normal in folate deficiency. This is the famous MCQs for the most of the post-grad examinations. Methylmalonic aciduria will be elevated only in B12 deficiency. The other options will be like folate deficiency. It will be normal. Next, we'll see the hemolysis anemia. Hemolytic anemia, it could be due to intrinsic problem or extrinsic problem. That is, problem within the red blood cell, or problem outside the RBC. And in the RBC, it could be due to a cell membrane problem or enzyme defect problem. And next is the acquired hemolytic anemia. You see, this is a broad classification of hemolytic anemia. The problem within the red blood cell, it could be due to hereditary or acquired. In the hereditary, first we'll see the membrane defect. I already told the normal RBC is a biconcave disc-shaped 7.5 micron size RBCs. So you can easily squeeze the circulation. Suppose if the RBC loses its shape due to condition called hereditary sperocytosis, spherical shape or elliptical shape or any other shape other than biconcave disc, there is a lysis. And next is the enzyme defect due to G6PD, that is a glucose 6-phosphate dehydrogenase enzyme. So what will happen? There will be free radical formation due to NADPH oxidase deficiency. What will happen? There will be lysis of the RBCs. This condition I will explain in the subsequent slide. About G6PD, we'll have a brief discussion. Next is the hemoglobin defects due to sickle cell disorder or a hemoglobin C disease or SA disease or thalassemia. And next is the acquired cause is the PNH, that is paroxysmal nocturnal hemoglobinuria. It is also an acquired membrane defect due to abnormal molecule called PIG-A, phosphatidylinositol-glycan A, and other enzymes in the RBC membrane. So remember, the hereditary is due to membrane defect or enzyme defect or hemoglobin defects. Acquired is the one and only it's the PNH. So it is within the RBC there is a defect. So because of defective RBC there is a hemolysis. And next is the extra corpuscular, that is, it is not within the RBC, it is outside the RBC. It could be due to a immune cause or non-immune cause. Immune cause means any, like, the body will produce its own auto antibodies, warm antibodies or cold antibodies. These antibodies are produced inside the body against the body's patient's own red blood cells. So eventually what will happen? There is a hemolysis. Or certain drugs also will cause autoimmune-like reactions. Whereas certain conditions, non-immune mediated extracorpuscular outside the RBC destructions due to chronic infections like malaria or mechanical trauma or hypersplenism. So what will happen in hypersplenism? The spleen, it is reticuloendothelial, one of the component of the reticuloendothelial system. It will engulf and capture and sequester. It will sequester the RBC and eventually causes destructions of the RBC. So hemolytic anemia is due to membrane defect or a globin chain or a metabolic disorder. So few words about hereditary sperocytosis. What will happen is the normal biconcave disc shape is lost due to deficiency of enzymes called spectrin and ankyrin inside the RBC. So the patients will present with hemolysis. There will be anemia. Because of anemia, there is a jaundice, and in the jaundice, the patients will have unconjugated hemoglobin. The patients will not have increased conjugated hemoglobin, and because of increased unconjugated hemoglobin, there will be excess gallstone formation inside the patient's gallbladder. So this patients eventually presents with cholelithiasis like symptoms, and because of extravascular hemolysis, there is splenomegaly. And remember, this is a famous MCQ. MCHC is high for this disorder. That is, mean corpuscular hemoglobin concentration is high for this hereditary sperocytosis. How to diagnose the condition? A simple test called osmotic fragility test. It is used to diagnose. It is sensitive but not specific. The test measures the in vitro lysis of RBC suspended in the solution of decreasing osmolarity. You can able to appreciate the hereditary sperocytosis, the spherical shaped RBC. Next, we'll see about the sickle cell anemia. So, the sickle cell anemia, the patient's peripheral smear will have a sickle shaped RBC. It is due to mutation in the beta 6 globin chain. What happens? The glutamic acid is replaced by valine, the enzyme. So, the normal biconcave disc shape is converted into sickle like shape. So, there is a hemolysis. So, the patients will have splenomegaly and other manifestations. So, the lifespan of RBC, which normally withstand up to 120 days, will be lost. So, the patient's RBCs will have shorter lifespan in 10 to 20 days. So, this is the manifestations, head to foot manifestations. The patients, because of sickling, what happens? The patient's blood vessels is occluded everywhere inside the systemic circulation and microcapillaries. What happens if there is occlusion? There is ischemia. Ischemia to the brain is called stroke. Ischemia to the heart, patients may present with angina or heart attack or a myocardial infarction. Ischemia to the pulmonary circulation, patients will present with pulmonary infarct or renal infarct. So, because of vaso-occlusion, there is a ischemia to the various vital organs. And another thing is there will be sequestration and destruction. So, sequestration means this unwanted or defective RBCs are sequestered in the spleen. So, that is the reason for splenomegaly in sickle cell anemia. So, initially these patients will have massive spleen. Eventually, because of vaso-occlusion, there is ischemia and eventually it causes infarction. So, the patients will have splenic atrophy. So, this is the condition in sickle cell anemia. Patients will have initial splenomegaly followed by splenic atrophy and autosplenectomy will occur. And in the hand, the patients will have sickle cell hand, and then there will be erection of penis called priapism. And then if there is a excess indirect bilirubin, so the patients will have pigmented gallstones. And then in the eye, the patients will present as retinopathy. So it has a lot of complications from head to foot. How to tackle the sickle cell crisis? Next we'll see. So this is a sickle shape, like a crescentic shape, sickle or crescentic, whatever you can call. So the normal biconcave disc shape is lost. So how to treat? First is hydrate nicely, then give 100% oxygen, and then pain management. Then you can think about blood transfusion and then bone marrow transplant. And then you should avoid the triggers like avoid hypoxia and avoid acidosis. These are all other clinical aspects to treat sickle cell anemia. And what happens with if you give hydroxyurea? This hydroxyurea will increase the production of fetal hemoglobin. The fetal hemoglobin, how it differs from adult hemoglobin. Adult hemoglobin will have 2 alpha and 2 beta, whereas the fetal hemoglobin will have 2 alpha and 2 gamma. So this is the reason we give hydroxyurea. And next is the dietary and lifestyle and other relaxation therapy. Next we see about the G6PD deficiency. That's the glucose 6-phosphate deficiency. It is a catalyst, the initial step in the pentose phosphate pathway. It's an X-linked, more than 300 variants identified. Around 130 crores probably carry mutant genes, up to 20 to 30% of Africans and 35%. It's also seen in Asian population. So it is associated with exposure to drugs like primaquine or sulfur drugs. So like anti-malarial, like if you use primaquine to patients with G6PD deficiency, the patients will present with hemolysis anemia. Or certain beans, the fava beans, also the patient, if you consume this certain bean variety also, if the patient is having G6PD deficiency, the patients will present as hemolysis anemia. It is the G6PD patients in the peripheral smear. You can able to appreciate a body called Hem's body. It is nothing but it's a condensed and denatured hemoglobin. And next, these patients will also have bite cells. Bite cells is nothing but the edges of the RBCs will have serrations like a bite. So this is the laboratory evaluation of hemolysis. I already told hemolysis can occur either within the blood cell or outside the blood cell. If it happens within the circulation, it is called intravascular. If it happens outside the blood vessels, either in the spleen or bone marrow, it is called extravascular hemolysis. The example for extravascular hemolysis is the sickle cell anemia and thalassemia. For intravascular, it is the PNH and G6PD. So how it differs? What happens in intravascular hemolysis? If there is a hemolysis, the patients will present as anemia, and eventually the patients will also have jaundice due to increase in unconjugated bilirubin. Remember, the jaundice in hemolysis anemia is not due to conjugated. Only in obstruction of the biliary tract, there is conjugated bilirubin will increase. Whereas in hemolysis, what happens is the unconjugated bilirubin level will increase. That means the body cannot conjugate the excess unconjugated bilirubin. So that is the reason for increased unconjugated bilirubin in hemolysis anemia. And apart from that, there will be hemoglobinuria and hemoglobinuria in intravascular hemolysis. You can see the hemoglobinuria does not seen in extravascular hemolysis. Whereas inside the blood vessel, if there is a destruction of RBC, there will be a hemoglobinuria. Similarly, if you check the urine, there will be hemoglobinuria and hemosideruria in intravascular hemolysis, but it will be absent in extravascular hemolysis. And in extravascular hemolysis, the patients might have splenomegaly, whereas in intravascular hemolysis, the patients will not have splenomegaly. So these are all the various differences between intravascular and extravascular hemolysis. Next is the immune-mediated hemolytic anemia. It is a premature destruction of RBC due to acquired antibodies directed against the red cells. Two tests which we commonly perform. One is a direct Coombs and indirect Coombs test. This flow chart will explain about hemolytic anemia. So if there is a hemolysis, there is a RBC breakdown. So the end product of hemoglobin, it is the bilirubin. So this bilirubin is converted to biliverdin. Biliverdin reductase. Eventually, what will happen? There will be excess bilirubin. That is the unconjugated. Remember, if there is hemolysis, there will be anemia followed by jaundice, and the jaundice is due to unconjugated bilirubin. This is one point. Next is because of hemolysis, there will be the bone marrow is intact. The bone marrow is not hypofunctioning. The bone marrow will hyperfunction in hemolysis to compensate the loss. So there will be hypercellular in the bone marrow, and the reticulocyte count also will be high. So that is the reason for erythroid hyperplasia in hemolytic anemia. And if it is intravascular or extravascular, there will be a hemolysis, and then the extravascular cause is due to spherocytes or sickle cell or a red cell fragments. In the intravascular hemolysis, if the patient is having a stuck valve or a stenotic valve, or the patient is having a DIC or PNH, or patient is having a condition called TTP, that is thrombotic thrombocytopenic purpura. So we will not go into detail about each conditions. So paroxysmal nocturnal hemoglobinuria. It is a condition. It is an acquired red cell membrane defect which causes hemolysis. It is due to a mutation in the RBC membrane which causes the defect in the PIG-A, that is phosphatidyl inositol glycan A, and then there will be defective GPA, that is glycophosphatidylinositol inositol linked gene synthesis protein defect, leads to hemolysis, which is detected by flow cytometry. The treatment is you can use a monoclonal antibody against C5, that's eculizumab. Last is the aplastic anemia. Aplastic anemia, it is the blood cells are produced in the bone marrow. A decrease in the production of red cells, white cells, and platelets will cause aplastic anemia. This results in low RBC, low WBC, and low platelet. A condition called pancytopenia. patients are susceptible to infections and decrease in clotting. There are many other causes due to like post chemo, post radiation, or viral infection, or certain antibiotics like chloramphenicol, or any autoimmune conditions can cause aplasia of the bone marrow. So before I conclude, to summarize, if there is decreased hemoglobin or hematocrit, then check the reticulocyte. If the reticulocyte, which is the precursor of RBC, is high, that means there is hemolysis or destruction or excessive blood loss. So the bone marrow will try to push more or reticulocytes, and eventually more RBCs will be formed. So suppose if the reticulocyte count is less, that means the problem, it could be in the bone marrow. The production is either defective or ineffective. Then check the red cell indices. Like two things I already told. One is a quantitative and another is a qualitative. In the quantitative, you will see hemoglobin, the hematocrit, and the RBC count. And in the qualitative, you will see MCV, MCH, and MCHC. So based on the MCV, you check whether the size is normal and hemoglobin content. So it is called normocytic, normochromic anemia. If the size is large, it is called megaloblastic anemia. The commonest cause is due to B12 or folic acid. If the size is small, so small size or decreased hemoglobin content, the mnemonic is TICS, thalassemia, iron deficiency, anemia of chronic disease, or sideroblastic anemia. So if the size is normal, it could be due to either a hemolytic or a non-hemolytic. Next is the increased conditions due to abnormal morphology. In the abnormal morphology due to defect in the RBC membrane, or there is hemoglobinopathies. Next is the environmental cause, and last is the enzyme defects like G6PD or pyruvate kinase deficiency. Thank you all for the patience and the wonderful opportunity.
So thank you for the wonderful session. I would now request Professor and Head of the Department, Dr. C.P. Luck ma'am, to share her comments.
Hello. Suranjini. ஏமாயிருந்து வரல பிக்சர் வரல ஓப்பன் பண்ணிட்டேனே கேமராவை என்ன பண்ணணும் இந்த பெல்லம் பண்ணுவோம் ஸ்லைடு தான் வருது இங்கேயா என்ன பண்ணணும் Hello, am I audible?
Yes, ma'am, you are audible.
Okay. Good morning, all. Good morning, all. Anemia is a very important topic for undergraduates, not only in your curriculum, and all of you will be facing in this anemic patients in your later in your day-to-day practice also. That's why we chose this topic. My great applause to Dr. Vasantha Kumar for his wonderful and excellent talk about anemia. I really wonder an anesthetist could talk so much in depth about anemia like a hematologist and pathologist. Excellent PowerPoint in which he covered right from pathophysiology to clinical features and treatment in elaborate manner. Due to this pandemic, students have no opportunity to see anemic patients in reality. His slides covered all clinical features beautifully, like you are seeing patients in reality. His methodological approach to lab diagnosis also was really excellent. Right now we are having recently we had all the lectures regarding RBC. His talk is really like a recap for all our lectures. He really covered everything. And a methodological approach of diagnosis of various anemias was really, he clearly explained in detail and excellently. In a nutshell, he covered a big topic anemia in depth in an easy and clear manner to understand for the undergraduates. On behalf of the Department of Pathology, TMCH, my sincere thanks to Dr. Vasantha Kumar. Thank you, sir. And I thank Dr. Jamna Rani for organizing a wonderful webinar with a wonderful speaker. Thank you.
Thank you, students, and thank you, the organizers, and thank you.
Thank you, sir. I would now request students to share their comments. Any two students to share their comments. Please unmute yourself and also switch on the camera while you're talking.
Good afternoon, ma'am. This is Lavanya here. My name is Lavanya. The session was very clear and all aspects of anemia was covered, and the session was in detail with all lab investigations, and the comparison table had a lot of aspects on anemia, and sir's explanation was very clear and to the point. The pictorial representation about the clinical manifestations of different types of anemia was also very clear. At the end of the session, I gained a lot of information on anemia and its clinical approach. It was like a quick refresh of the important topic, anemia. Thank you, sir, for this session. It was very useful and informative.
Thank you, Lavanya.
Good afternoon, ma'am. Am I audible?
Yes, you're audible.
The session today was a wonderful session, ma'am. Over the last few weeks when we did anemia, all the things were, it was a good revision for us to cover all of them in this 1 hour session. Sir also gave us the classification table, the differentiable table actually, which was very useful to find out the differences between each anemia, and also the treatment policies. Sir had explained patiently and wonderfully, and it was a great exposure to this kind of a session, ma'am. Thank you for organizing this kind of a session, and sir for this wonderful presentation as well.
Thank you, Nithilan, for your feedback. I would now request Dr. Umesh Krishna, second year postgraduate, to deliver vote of thanks.
It is an honor that I have been asked to offer a vote of thanks on this occasion of webinar on anemia conducted by Department of Pathology, TMCH. On the behalf of my department, our college and entire management, I would like to immensely thank our chief guest who has spared his vital time from his busy schedule to enlighten us with his experience in anemia. He clearly explained the different classification of anemia and in detail how to clinically identify them. Our chief guest name, Dr. Vasantha Kumar, Senior Consultant Anaesthelogist, Head of Medical ICU and Toxicology, MeenakshiMission Hospital, Tanjavur. And in this occasion, I would also like to thank our chairperson, Dr. M. Mala, Managing Trustee and Tanjavur Educational Trust. And I would also like to thank our Dean Sir, Dr. N. Gunasegaran Sir. And I would also like to thank our Dean Academic Sir, Dr. K. Ravindran Sir, And I would also like to thank our Medical Director, sir, ma'am, Dr. Kumar Lingaraj, ma'am. And I would also like to thank our Medical Superintendent, sir, Dr. K. Sivaprasan. And I would also like to thank our Department HOD, Pathology Department HOD, Dr. C.P. Lak, ma'am. And I would also like to thank our Sara Kurvila, ma'am, Professor in Department of Pathology. And I will also like to thank our other faculties in our Tanjavur Medical College and my colleagues, and also the students who have attended gracefully. I hand over the dice to Sivaranjini Doctor.
Sir, actually, a postgraduate of our department has asked a question, sir. Sir, can you say a few words on post-operative anemia? Sir, kindly unmute yourself, sir.
Yeah, post-operative anemia mainly due to blood loss. So the word post-operative starts before. Ideally we should know start before. It's like a perioperative, we can say. Like perioperative means before anesthesia, during anesthesia, and after anesthesia. So if you give adequate perioperative care, before the start of surgery, the nutritional status if you address, and during intra, if the patient if you use tourniquet or if it's adequately planned, the intraoperative blood loss will be decreased. So that is the main reason. And if in post-operative, I often see in the most of our unit, like if the hemoglobin is 9 or 10 or 11, still they will transfuse. So that is also not needed. So if the hemoglobin is somewhere between 7 to 8, still we can wait. There is no need to do immediate transfusion. And then we should address other coagulopathy also. Mainly we should notice what is the drain volume, what is the patient's nutritional status, and next is the patient is having any coagulopathy, that also should be addressed. So the concept is simple: treat the cause for anemia and then transfuse the appropriate blood components. Suppose the patient's platelet is less, because of low platelet, the patient is bleeding, then you can transfuse the platelet alone. But don't use formulas like give 4 FFP or 4 platelet. So you can see not only the PTCT or this PTA, PTT, INR also. You can see if the tertiary care unit is there, you can think about doing tech studies also. Like especially for liver transplant, that we often do thromboelastogram. So in that, the components of the defective components in the coagulation cascade will be easily picked out. So only that defective cells alone will be, that is the component cell alone will be transfused. So that is the ideology. And based on the trick and twist trials, what they recommend is if the hemoglobin level is 7, then there is no need to transfuse also. Still you can accept the hemoglobin level. So this is the thing. Any other questions?
Sir, can you enlighten us about the role of plasma expanders in case of acute blood loss anemias?
About acute?
Acute blood loss, sir. When the patient comes with any acute blood loss, the role of plasma expanders in what time, sir?
Yeah, if the patient, blood should be replaced with blood based on ATS guidelines. So first is the component is, the ratio is 1:1:2. That is crystalloids, colloids, and blood. This was the previous recommendations, but now the current recommendation says, the ATLS recommendation is, if there is acute blood loss, first is give compression over the bleeding site or apply tourniquet, and then minimize the blood loss, active blood loss. And next is the component of crystalloids and colloids and blood should be 1:1:1. This is one thing. And next is based on the crash 2 trials, we can give tranexamic acid as an infusion for 8 hours, and before that we can give tranexamic acid 1 gram. So this is an anti-fibrinolytic agent, tranexamic acid. So 1 gram stat over 10 minutes followed by 1 gram infusion over 8 hours. So this also will prevent the excess fibrinolysis. So crystalloids, colloids, blood should be in the ratio of 1:1:1 based on the current ATLS recommendation. And next is based on the CRASH 2 trials, we can give anti-fibrinolytic agents like tranexamic acid. And don't forget about compression or applying tourniquet to minimize the blood loss. Or if you identify the culprit blood vessels, then if you have an angiogram, then you can do embolization. If the intervention radiology is available, then you can ablate the feeding vessels or the bleeding vessels. Still it is not possible, then don't wait, take for immediate laparotomy or surgery and then ligate the blood vessels and laparotomy and proceed. So minimize the blood loss and then replacing the blood loss. This is the 2 key. Any other questions, please?
So no more questions, sir. Thank you, sir.
Any other questions, please?
Sir, no more questions, sir. Thank you. Thank you for the excellent presentation and thank you for your patient explanation. And thank you, sir.
Thank you, students, dear students, in the Toxicology College, and especially to the Department of Pathology for the invitation and giving me this golden opportunity to interact about an important topic about in an anemia, the clinico-pathological aspects. Thank you one and all. Thank you very much.
I would request all the faculty members to switch on the camera so that we can take a screenshot with Dr. Vasantha Kumar, sir, virtually. Rajesh sir, Sangeeta ma'am, Balamurgan sir. Vignesh sir. Thank you, ma'am. Thank you, sir. Thank you all.
Thank you all. Bye.